This video is part 1 of Chapter 10, Abnormal Psychology for PSY 110S, the Psychological Sciences. In this chapter, we're going to start by looking at the document that is used by medical and mental health professionals to describe and categorize psychological disorders. And we'll talk about its advantages, disadvantages, kind of how it's structured, how it's changed over time. Then the chapter will shift to giving you descriptions of 6 of the major categories of psychological disorders. And then the chapter will conclude with a discussion of treatment approaches. Before we go any farther, we need to work through how difficult it is to define words like normal and abnormal when you're talking about elements of personality, of behavior, of thinking, of emotion. One way of thinking about normality and abnormality is to think about typicality, like is the behavior or emotion or thought unusual? Is it atypical compared to other people? What this refers to is the behavior, is the thought, is the emotion infrequent on a statistical basis? You could also, though, talk about normality and abnormality in terms of the degree to which the behavior, the thought, the emotion interferes with everyday life. So that's what we mean by the word maladaptive. If a process of thinking, if the way people feel, if the way they act gets in the way of them being successful, interferes with work, interferes with relationships, interferes with school, interferes with your ability to not break the law, for example. All of that is about adapting to what you need to do to be successful in life. And behaviors that don't do that would be considered maladaptive. You could also talk about normality and abnormality in terms of the degree to which people experience distress. So the question you ask there is, are the behaviors, thoughts, feelings distressing to the person? And then there's an important addition here. Is what you're seeing distressing to other people around them? And that can be very problematic because there are lots of ways that people behave that aren't personally distressing to the individual engaging in the behavior, but they're certainly problematic for the people around them. And you have to ask the question, when does a person being odd, when does it cross the line to being overtly abnormal and therefore needing to be addressed? And finally, you could talk about normality and abnormality in terms of the rationality of what you're seeing in another person's actions, thoughts, and feelings. Rationality refers to how people are perceiving reality. And in some cases, for example, if a person has delusional beliefs that they are a being from another world, or that they are a messiah, or that they're being pursued by alien life forms from another planet, those are considered irrational thoughts. They are deviations clearly from reality. So there are lots of different ways to think about normality and abnormality. Some other researchers, Rosenhan and Seligman, for example, focused on maladaptiveness, primarily in the form of being dangerous to self. They talked about vividness and unconventionality, meaning that the behavior stands out. They talked about unpredictability and losing control, followed by irrationality and incomprehensibility, causing others discomfort, and then finally violating moral standards. Now you can see how in their definition there are some concerning things there. Just being odd or unconventional, just being someone who violates certain moral standards, does that mean you're mentally ill? And that's where some of the difficulties come into play. It's defining what's normal and not normal is impacted by culture. It's impacted by beliefs and values about what people are expected to do, what they're supposed to do. So it's not surprising that sometimes in cultures, including ours, that the way we define normality and abnormality can be used to harm people who are in the minority. So keep that in mind as we proceed. We're going to talk now about the DSM, the Diagnostic and Statistical Manual of Mental Disorders. And as I mentioned before, this document is the set of guidelines in the United States that medical and mental health professionals use. It's like an agreed upon set of principles and language. They use the information in this document to make clinical decisions, to diagnose people, to describe their behavior, and they use it as a guide for determining then what kind of treatments to use. The first version of the DSM came out in 1952 and was fairly limited in terms of how many disorders were described in that original document. You know, the intent early on was to aid in accurate diagnosis and the delivery of treatment based on classifications of disorders. The original document, about 60 disorders, and that's compared to over 400 now. The DSM-5, which is the current version, although there has been a text revision published more recently than 2013, the American Psychiatric Association is the governing body that organizes the continued evolution of the DSM over time. Psychiatry, just to make sure you understand who is in control of the DSM, psychiatry is a medical specialty. So these are medical doctors who specialize in mental disorders, and they pull together as a board of contributors to the document, psychiatrists, psychologists, counselors, but it is a document that's very much governed by what you could call the medical model, because it originates out of a medical specialty, which is psychiatry. So it's very determined by this model where you look for symptoms that hang together, that cluster together and suggest a particular diagnosis. Once you have the diagnosis, you can choose a treatment plan appropriate to that diagnosis. The text revision came out in 2022, and what usually happens is you have a version of the DSM. So the DSM-5 came out in 2013. As soon as it's put into practice, because insurance reimburses based on diagnostic codes. So whether you're talking about mental disorders or physical illnesses, whatever, you get a code and it goes into the medical system, and reimbursement is based on those codes. Once the 2013 document went into practice, then the APA collects more information and refinements are made. And that's where the text revisions come into play. So an updated version of the DSM came out in 2022. In the DSM-5, there are 20 major categories. Since this is an introductory level psychology course, we're definitely not going to cover them all. If you're interested in this type of material, you should probably look into taking a course in abnormal psychology. The manual has taken a number of different forms. In previous versions of the DSM, there was an axial assessment system where you had various axes that intersected, and that was deemed to be ineffective or to have flaws and problems in the way disorders were being described, but also in how assessments were being made. So they've moved to a non-axial assessment system that involves clinicians whether they're psychiatrists or psychologists, looking at symptoms and symptom severity and the degree of impact on adjustment and adaptation to everyday life. The hope is that it will be more clear. It will create more consistency across clinicians in terms of deciding what's being seen. Now, just to give you a snapshot of the complexity of the DSM, the modern DSM, you have this very long list of disorders. So the first 20 are categories that have been used to describe the various forms of disorders that people can have. And there have been some changes over the decades, moving some things around. For instance, anxiety disorders used to include obsessive compulsive disorder. Those have been separated now, such that anxiety disorders stand on their own as distinct from obsessive compulsive and disorders related to it. Trauma and stressor related disorders used to be considered part of the anxiety disorder grouping, and they are popped out and listed on their own separately from the anxiety disorders. And some other things that have been occurring within the DSM over the last 20 years or so is that some of the disorder categories are now being thought of as a spectrum of disorders as opposed to a cluster of discrete disorders. So, for instance, schizophrenia is now being discussed and described as a spectrum of many different expressions that have a similar core. Similar to the way autism, which is a neurodevelopmental disorder, is now described as autism spectrum disorder, as opposed to 3 separate diagnostic labels used to describe different patterns. So instead it's being described as a spectrum. So that's a change over time. It remains to be seen whether that's going to be helpful, not helpful, whatever. Another thing to keep in mind is that the DSM is the people who put it together. They work very hard to try and create categories and descriptions of categories that can lead to effective, efficient, and reliable patterns of diagnoses. It's arguable the degree to which that is successful, and research is ongoing to determine some of the problems. And that's why the book keeps getting updated routinely. Another thing to think about, the DSM is not the only diagnostic manual in the world. In fact, the International Classifications of Disorders, the ICDM, is an international model that includes all kinds of medical and psychological conditions. And what I've been seeing in recent years is kind of a movement in the direction of making the DSM more and more consistent with the ICDM, so that there is some seamless connection for researchers, for clinicians, regardless of what country they're in. So some are speculating that the DSM will simply kind of fade away, and the ICDM will take its place. I'm not sure whether that's true or not true. We'll have to see. But it is true that in the DSM, you have some pages that show the connections between the diagnostic codes for the DSM and the diagnostic codes for the ICDM. Now, the DSM has strengths and weaknesses, and you can go down the rabbit hole of looking at all of the criticisms as well as the advantages of the manual if you want to. The strengths, it helps clinicians to have a shared language for describing what they're seeing in terms of symptoms. It gives them the ability to do research using common language. It is designed to reflect the state of the research literature that surrounds all of the categories of disorders. And that means that from one version of the DSM to another, as the research database improves and changes, the DSM has to adapt to reflect the current state of knowledge that we have. The connection to insurance can't be underestimated here. In order to get insurance reimbursement for a medical condition, for a psychological condition, you have to have a clinician be able to label and document what it is that people have and what they're being treated for. So insurance criteria really require that you have specific diagnostic codes. And then finally in the DSM-5, the so-called bereavement exclusion has been removed. What that refers to is this exclusion that used to be present where clinicians were not to diagnose someone who was currently in a state of grief after the loss of a loved one for depression. They weren't to diagnose them as depressed. Even if they met the clinical criteria for depression, if they were bereaved, it didn't count as depression. And that was seen by many clinicians as handcuffing them and saying that, okay, I have this person who's acutely depressed and their depression is lasting longer than 2 weeks, but you're telling me I can't treat them for depression simply because the depression was prompted by loss. So that was eliminated. It gave clinicians discretion to look at what they were seeing in their clients and treat them accordingly. The weaknesses are many. You can look at a couple of different broad categories. Many aspects of normal behavior can sometimes be categorized as fitting the descriptions of psychological disorders. Idiosyncrasies, oddness, quirkiness of people can sometimes fit, especially the personality disorder characteristics. There's also, going along with this, if you look at the big picture of the DSM over the course of its history, there are many patterns of human behavior that used to be described as mental illnesses that are no longer seen as mental illnesses. So, for example, homosexuality has moved from being clearly described in the DSM as a mental disorder, as a mental illness caused by a variety of factors. And that meant that clinicians could propose treatment protocols to try and reverse it, to try and change it. Now, by modern standards, this was seen as inconsistent with the research literature and was also seen in many circles as a violation of people's independent rights. So over the course of the DSM, you had a steady sort of you had a movement from version to version that over time redefined homosexuality in the context of normality. First, shifting from homosexuality being clearly described as a mental illness, then only categorizing it as a mental illness if the person didn't want to be gay, and then eventually eliminating it as any sort of disorder. We're starting to see some similar kind of practice in redefining other sorts of disorders, but that's an obvious one where cultural values and beliefs were directly affecting whether or not a specific pattern of behavior was defined as a mental illness. So many strengths and weaknesses. The cultural issue is really problematic, especially when you look at cultural values and attitudes about normality. especially with respect to gender and sex and sexuality, but also with respect to personality. There's a whole category of personality disorders that are very controversial, have always been controversial, because they're values-based. They're about who does your culture find irritating? Who do they find problematic? And just because people are problematic doesn't necessarily mean that they're mentally ill. So there are many, many ways in which the DSM has flaws. There are other ways in which it's very useful. Now, your authors mention issues related to psychiatric labeling and diagnosis, and its connection to stigma. Stigma refers to marking people based on their category, based on their social group, for rejection and avoidance. Certainly, people with mental illness historically and presently have been marked for social exclusion, and some of the assumptions that tend to be made about people with mental illness is that they are more likely to be dangerous and violent. They're more likely to be unpredictable. They also tend to believe that people with mental illnesses are childlike and incompetent. They may be seen as blameworthy, and in some ways unworthy of participating in just the regular walks of life. These are people to be avoided, people to be pushed off to the side, and so on. So the stigma related to mental illness is a real thing, and it's a problematic thing. Diagnostic labeling can be, for many people, very validating, meaning you finally have a name to put on the thing that you are experiencing, that you're feeling, but at the same time, it can lead to prejudice and discrimination. Now, some of you may have seen the film Joker. When I teach a course called Movies and Madness, we often watch Joker because it's a really complicated set of messages where they're pointing out this social cultural issue of stigma, but then the storyline is you should poke the bear, in this case people with mental illness, at your peril, because if you do ignore us, we will kill you. That's certainly a very, very negative and stigmatizing message. These kinds of messages can lead to biased perceptions, and our perceptions then become, they lose objectivity. So it leads to social isolation, lack of access to education, to work, to all kinds of things that people can have. So mental illnesses definitely can lead to stigma, and this is especially true for certain categories of disorders. The disorders where the strongest stigma exists tend to be the disorders that also include psychotic symptoms such as hallucinations and delusions. So disorders like bipolar 1 and schizophrenia, but also disorders like PTSD, especially in connection with first responders and military personnel, have real strong stigma biases attached to them. People with mental illnesses are often, and I teach a whole class on this, they're often misrepresented in TV, film, and other kinds of media. The real problematic area is the tendency overwhelmingly to present people with mental illnesses as violent and dangerous to others, despite the fact that there is evidence that shows that the connection between having a mental illness diagnosis and violent behavior is weak at best. Your authors remind you, keep the person and the label distinct, and try not to assume that that a person is the sum total of their diagnoses, because that leads to prejudice and discrimination. There are a variety of ways that psychologists and psychiatrists talk about the causes of mental illness, the causes of abnormal thinking, feeling, and behavior. Most causal explanations can be put into boxes associated with the 4 major research approaches that we talked about all the way back in Chapter 1. There are biological explanations, behavioral or learning-based explanations, cognitive explanations, and sociocultural ones. All of these are required. If you're going to have a full understanding of the origin of mental illnesses, you need to use all of these approaches in concert. And that's why at the present time, the so-called biopsychosocial approach is dominant, because it helps create a holistic way of thinking about and describing psychological disorders. And that concludes part 1